Dear friends, dear colleague, welcome back to the Essential of Digital Dentistry and to the Mangano Digital Academy. In this lecture, we'll talk about custom-made scaffold for bone regeneration. It's a topic that is quite hot at the moment. We are using this scaffold on a regular basis in our private practices and in university. They work very well for the regeneration of small alveolar ridge defects. So we don't use them for huge defects, but we use it for small defects, and we have also a perspective and project for using them with huge defects together with growth factor. But let's see what we did in these years and what we are currently doing at the moment. Digital dentistry. Once again, we go to digital dentistry. Digital dentistry is based on 4 essential steps: the data acquisition, data elaboration, production, and clinical application. In this case, we are talking about custom-made scaffold for bone regeneration. We are talking about onlay graft, and in these grafts are produced usually, at the moment, we produce them using a milling unit, so with a subtractive technology from a blank. But of course, the perspective is for the future is to 3D print this scaffold in order to not waste any material, because these materials are quite expensive. And actually we are using, and we have always used, synthetic porous hydroxyapatite in combination with beta-3 calcium phosphate. So technically we have a biphasic hydroxyapatite, and this is the material that we are using. So the question is, can we mill custom-made scaffold for bone regeneration? The answer is yes, of course we can. And there's a lot of literature, and at the end we found 8 clinical studies on milled scaffold and some reports, of course, because the literature is still not so huge in the last years. But the interesting thing is that from the milling we are shifting, the attention is shifting to 3D printing, and the materials are the synthetic material now are at the center of the attention, and they have replaced, for example, allograft or xenograft. They were used more in the past for the only graft, but for this purpose, obviously, synthetic material, they fit better the needs of the case. And this is a list of the publications made by different authors recently in the last 10 years on the topic. We have worked hard with this concept in the early 2000 with Professor Aldo Macchi, with Professor Figliuzzi from University of Catanzaro, and other co-workers. This is a case of Professor Giuseppe Luongo, published in Biomedical Research International recently in 2016. It was a retrospective multi-center clinical studies on 15 patients. This is the concept basically. The tooth was removed, there was a bone defect, the bone defect was investigated in 3D after a proper segmentation. Then the STL file derived from this segmentation was exported, in this case from the software from Materialize Mimics, to other software for the design of the custom-made only graft, the custom-made scaffold. Then it was re-imported in Mimics to check the perfect fit and adaptation virtually. And then, as we can see, the scaffold was prepared with a hole for the fixation screw. The design of the custom-made scaffold is quite tricky because it needs to be experienced in the field of computer-assisted design. So usually this service is provided by companies where trained and skilled operator can design the scaffold for you, based also on your indication. For example, BTK, an Italian company in Veneto, provide this service, and we are using actually the service from BTK for this kind of cases. And as we can see in Rhinoceros, another software, the scaffold with the hole prepared for the fixation screw, with the feature of the scaffold inside in the hollow portion. And we can fabricate actually the scaffold by means of milling with a Roland machine. We start with a DWX51, now we're using the DWX52, they work very well, and this is the 3D bone by BTK, milling of the custom-made scaffold in synthetic porous hydroxyapatite, and then the case made by Professor Giuseppe Luongo, preparation of the recipient side, scaffold placement and fixation. Eventually we can cover the scaffold with a membrane, but it's not mandatory in this case. The holes before the placement of the scaffold can help bleeding a little bit, and so to enhance the integration of the scaffold. And 6 months later or 8 months later, sometimes it's needed to wait more, we can see the incredible integration of the scaffold. We can remove the fixation screw, and then Professor Luongo placed conveniently the implant in a huge quantity of bone. So this is the application for small defect for alveolar ridge augmentation, and it works perfectly because it grants you 3, 4 to 5 millimeter bone horizontally and vertically, and it is perfect for placing the implant, as we can see here. And it's the CBCT control in the cross section confirmed that the implant was placed correctly thanks to the new bone, the regenerated bone. And after 3 months of submerged healing, we can uncover the implant and proceed with the prosthetic restoration, and everything worked very well and predictably. For small defects, if the surgeon is capable to handle soft tissues very well, then the surgery is definitely faster, because you don't need to adapt manually a graft at the anatomy. The graft is already perfect, so you need to fixate, and you need to provide fixation of the scaffold and nothing more. And then you need to cover it properly, so the mobilization of the flaps and the sutures are key. Handling properly the soft tissues is key, but after this, basically, it's a biological thing. And here you can see all the different radiological phases in 2D until the case is being completed. We have worked with this principle even before, in the early 2000s, with Professor Jamil Awad Shibli, with Professor Aldo Macchi. Professor Aldo Macchi introduced this concept. Professor Shibli made these beautiful cases in the University of São Paulo, Brazil, and we published together a case of alveolar ridge augmentation, mainly in the maxilla, in this case with very predictable results. Usually at the time we used a biocoral graft, and the graft was a little bit huge in order to prevent a certain rate of resorption that was expected, but 8 months later anyway it worked very well. We didn't have the preparation of the hole for the fixation screw. Now we have it. This is another case, posterior mandible, made by Professor Figliuzzi in the University of Catanzaro. As you can see, I'm talking about multi-center studies, sometimes prospective, sometimes retrospective, with several cases made by different operators. So it worked quite well in the hands of different experienced operators. As we can see, Professor Aldo Macchi designed the scaffold, University of Varese. Professor Figliuzzi made the surgery. It worked quite well because the surgery was fast and quite predictable. The adaptation of the scaffold was perfect. Handling the soft tissues is key. Once again, you need to expect a little bit of resorption 8 months later, but anyway, the restoration was made without any big trouble, and the scaffold integration was confirmed by the histology made by Professor Piattelli and Professor Iezzi, Giovanna Iezzi. New bone formation, new bone instead of the biomaterial. So this procedure is capable to grant bone regeneration, even if, of course, vertically we need to expect some kind of resorption, and the posterior mandible is the most difficult, area to be regenerated, obviously. But the technique is important to me, not only the biological side, but the technical side. Professor Aldo Macchi performed also sinus augmentation with custom-made hydroxyapatite scaffold, and they worked very well. We are in the early 2000s. And Professor Macchi designed also the guide for the lateral window, and it worked very well. It was one of the first publications on this topic, together with the publication of Professor Mandelaris in the US. So we can use one block of biocoral or porous hydroxyapatite after we have provided an access with the lateral window that is sufficient to place the block. And in this case, there's a lesser risk of membrane perforation or losing the material inside the sinus, because the block is huge and everything is more controlled, and it fits very well. And this is the surgery. We use it to perform double surgery on the right and on the left, and as you can see, the perfect adaptation of the scaffold and the bone regeneration granted after 8 to 10 months. Confirmed also by the combined computer tomography. This is the other side, and another case. As we can see, the design of the window, the bony window for the access to the sinus, and the graft designed as well. Obviously, milling means, I mean, losing a lot of material. That's a pity, but now there's the second option. After 15 years, 20 years of clinical application, we are shifting to the 3D printing of biphasic porous hydroxyapatite, and it's possible now. So we are going to start a new trial for the use of custom-made onlay bone graft, 3D printed in this case, in ceramic, in porous hydroxyapatite, in biphasic hydroxyapatite. And this is the control of this other case, and 6 months later, and the implants placed with a combined computed tomography. What can we say if we talk about scientific evidence? Once again, the evidence is low because obviously we are talking about very few studies, but the potential is really high and it's very interesting, particularly if we talk about, I mean, 3D printed hydroxyapatite and beta tricalcium phosphate, because that way we could save a lot of material, control the porosity, control the inner portion, the hollow portion of the scaffold, and together with the possibility to, I mean, seed and stem cells, for example, or growth factor on the scaffold, then we can enhance the power of the regeneration, enhance the power, the potential, the regenerative potential of our scaffold, and have a faster and more stable osseointegration. So we have really, I mean, different solutions. We don't have so many studies. The evidence is low, but I think there's really an high way to study this technique, because particularly, I told you, in small defects, this is very interesting, very, I mean, reliable from the clinical side, and it can help the clinician to work very well and to save time, and of course to make the surgery a little bit more approachable and easy. And this is very important, I think, and it is one of the advantages of digital dentistry. So thank you very much for your kind attention.